And I'm Representative Mary Lou Dickerson. We're the Eric and Mary Lou Act today.
We have a couple of things to just to announce and remind you about this series. So it's sponsored by this Workforce Evidence-Based Practice Seminar Series. It's sponsored by the School of Social Work and our Evidence-Based Practice Institute, and as you can see, you can find the schedule for this on that website right there. As you can see, we've changed the time from from its former time, starting at 12:30 to 12:15, and obviously only the people in this room know that the change has happened, but we'll continue to remind people about the change in time so it becomes clearer.
And we'll go longer, right?
Hopefully that people will want to hear what we have to say. So the lectures are available on YouTube and the website. You can also gather information, and we have a whole bunch of information around trainings and variety of activities, as well as the topic we're going to talk about today, which is House Bill 2536. There's a great deal of information related to it on that website with frequently asked questions and descriptions of it, and we'll continue to add information about it. So let me first introduce Mary Lou, although many of you, she did introduce herself, but there are some things about Mary Lou that people might know, and one particular one that I found out, which may in fact be public shaming of you, but we'll see whether that's the case.
What's that?
Mary Lou has been a member of the legislature from the 36th district for 18 years. She's contributed in many, many ways to child safety and behavioral health and many, many, many areas. And I want to just mention one, and by the way, Mary Lou is a social worker, which I'm often reminded by my family members that people who actually bring about change often have backgrounds in social work and have MSW. So this is a nice place to be in, and nice to be with Mary Lou, who has really, really designed and used her career to really bring about positive things in the lives of people in this state. Mary Lou's the recipient of quite the extraordinary award. I was, and I, having worked with her very closely in the legislature, see this as such a perfect title for the award. It's called the Intercontinental Smackdown Champion.
I forgot about that.
And it happened to be, some of you probably followed Mary Lou's work on toxic toys and her work to bring about changes in that. And the award was given by an advocacy group called Fuse for her extraordinary work, both with legislators, getting them to change and in fact vote so there would be monitoring of these toxic toys, and shaming the toy industry into behaving in an appropriate way. So I like that.
Eric, you are too kind.
Yeah, well,
now I'm going to have to say something about him. We'll be thinking about that during the lecture.
So what we thought we would do is we're going to have a conversation about this evidence-based practice bill. We have lots and lots of information, and we'll kind of intersperse our slides and information with our dialogue together. I think it's a format that sort of lends itself to the work that we've done, and we really want to encourage questions here because this.
In fact, let me just say that the quality of this lecture, in part, will be based on the questions that you ask. So you all have some responsibility in how well this lecture goes. Oops.
All right.
I can't touch my mic, I've learned. We thought it would be good to give some context for how this bill came about. Right?
So this state has really been been in the forefront of changes in how children's services are implemented. And many of the changes, obviously there are many people here who do terrific research and develop programs, and there are wonderful provider organizations, but there's been a great deal of work that has driven emphasis on evidence-based practice. And back in 1997, there was a bill that was passed called the Community Juvenile Justice Accountability Act. You want to talk a little bit about what that was about?
Well, in part, that act said we want to invest our funds in evidence-based programs. WSIP, the Washington State Institute for Public Policy, which is an arm of the legislature, had developed research that showed us that there were 3 evidence-based programs that paid off in terms of effectiveness in working with juveniles in the juvenile justice system. And so that bill in part said, look, we want to invest the state community dollars into that. The state had a practice of giving counties funds to invest in services for juvenile justice. And so now we were being more directive. They had to be evidence-based.
There was, again, nationally, having a legislative act saying that dollars in juvenile justice that were spent for youth who were on parole or probation, if in fact the juvenile justice system was going to purchase services, they could only purchase services that had met the criteria of having being an evidence-based practice, as identified by the meta-analysis that the Washington Institute of Public Policy had done. So essentially, the 3 ones that actually were funded heavily were multisystemic therapy, functional family therapy, and aggression replacement training, ART, MST, FFT. And it became, within the legislature and with legislative staff, the T's became a kind of the coin of the realm, the topic of discussion.
Right, that's because legislators couldn't remember all these words. Legislators are generalists, and they don't remember these long technical words.
So how I mean, you were there during that time. How did that go? I mean, what was the conversation?
That went pretty darn well. First, there was resistance at the county level because everybody had their pet way of treating juveniles. My program works. I have this gut feeling that it works. And that had to be replaced with these programs that had already proven effective. But it didn't take long, and the counties were seeing a payoff. They were seeing that these programs worked, and the kids who received the benefit of the programs were getting into trouble less, and there were fewer victims. And the number of crimes were just going down, down, down. So although nationally, juvenile crime has gone down for the last 15 years, in Washington State, it took a nosedive, appreciably down, much more so than the national trend. And this has saved the state millions of dollars, so the legislature paid attention to that.
Wasn't it, Mary Lou, partly a function of potential capital expenditures? Their prediction was if the crime rate continued to go, the state would have to invest in all these new prisons and all these new juvenile justice facilities.
Exactly. Legislators have been concerned about the trends and the number of crimes and what that meant in terms of those investments. And because of those investments and because of something called JDAI, which I probably don't even remember the real name for, there was an emphasis on not increasing bricks and mortar, but instead putting money into programs that worked. And that paid off tremendously. There was not a need for new capital investment, which can be hundreds and millions of dollars.
So, I mean, I think, again, it's always been interesting to me, and I think it's been interesting to other policymakers, that the driver for implementing evidence-based practice came out of juvenile justice, even though these programs were developed within the context of behavioral health researchers who were developing these programs.
Washington State is known around the country as one of the very top states for juvenile justice now, because we chose to make that investment some time ago. Now, there are other bills. We should talk about the other bills. Would you
go back one, Gabby? Thanks. I don't think we'll get into the details unless you make me do this, and you really want to do this, Mary Lou. But there are a whole host of bills and court settlements and directives that have existed that really kind of create a pathway and have sort of created a map towards what we think now is this House Bill 2536, which is really going to require our state to move cross systems in child welfare, juvenile justice, and behavioral health into evidence-based practices. And again, we just list some of those. Let's go, and as you can see, there are many programs. Like I just want to, maybe we want to comment on how. Pardon.
You wanted to comment on 1088?
I think that being that it was your bill,
okay,
you probably should comment on it.
You can comment on something else.
All right, I'll find something else to comment.
Okay, well, let me just comment on 1088, if you go back there.
Here it is.
Oh, all right. House Bill 1088 really was the brainstorm of Eric Trupin and myself. Really, it was. And we wanted to make sure that when children receive mental health services, they're going to be receiving services that are effective and coordinated. And we wanted to look at other issues such as coordination between social workers and nurses, psychologists, maybe even a few psychiatrists, right? And we wanted to see those disciplines work together for the benefit of children and families. So that's some of what the bill did. Do you want to mention a few other things?
Well, I think the intent and the reality of the bill was to effectively do what's around in that circle. So, for example, Healthy Options is the fee-for-service aspect of Medicaid, and prior to this bill, there were only 10 sessions that a child and family would have access to, and the only people who could provide that service was a psychiatrist. So one of the expansions of Healthy Options was to double the number of sessions that were allowed, as well as expand that practice to social workers, nurse practitioners, and psychologists. So that was a very, very clear who actually can in fact provide services in a coordinated way, who has the additional skill sets to do the psychosocial interventions that are often necessary.
Of course, in terms of who has those additional skill sets, we needed to have people who were trained.
So again, that's partly what we've tried and to initiate with this workforce initiative, where we've developed, and Sue Kearns and a number of other people, but Sue has taken leadership in interdisciplinary courses that exist between that actually are done through the psychology department, where social workers and psychologists and special educators and a variety of people are together learning evidence-based practice in an interdisciplinary way. That was a strategy that we wanted to develop, and has really taken off and has been a very, very positive direction.
So I'm hoping we can just stop for a minute and ask you questions. I basically, since this is supposed to be an interdisciplinary audience, I'm wondering how many of you are social workers? Raise your hand. Social work. Okay. Any nurses in the audience? No? How about psychologists? Oh, lots of psychologists, yay. And psychiatrists. And yes, okay, great. So this is an interdisciplinary group that in part came about because of that bill.
So as Mary Lou indicated, there were many values that were imbued or part of this House Bill 1088, and early identification and coordination and emphasis on treating children within the context of their family and integrating families into treatments. Again, as we are familiar with most of the evidence-based practices, that the most effective, particularly ones for children with systemic problems or families with systemic problems, that family involvement is really a key, and that we wanted the system to focus not just on pathology, but also function on the resiliency and strengths of families in a culturally competent manner. We'll go to the next one.
So I just wanted to mention that Eric's group, the Evidence-Based Practice Institute, was key in helping to pull all this together and develop the training aspect of how we take a workforce that isn't particularly trained in evidence-based practice and move them so they are very knowledgeable in evidence-based practice.
Because clearly, and this is where, and many of you are either aware of it from personal experience or know about it, is that it's often the case that we, within our various professional schools, even though we have some fabulous faculty members who are experts in evidence-based practice, it's not necessarily the case that someone comes out of either the School of Social Work or out of psychology, psychiatry, nursing, actually with a skill set and prepared to actually implement some of these evidence-based practices. So we were very eager to move in that direction and continue to move in that direction. So not only will our graduates have a knowledge base, but actually be able to hit the ground running and be able to not only implement these practices, but influence the providers who in fact are hiring you all in these settings.
So Eric, how many people do you think have been trained in evidence-based practice over these last several years?
What do you think? So how many people have we had in our various...
We've had several hundred students come through. Well, at least over 100 students.
Yeah.
Mm-hmm.
Yeah. And I don't mean to say that there aren't trainees that go through our programs who don't have these skill sets, but in fact what we've intended to do is really focus and identify on capacity to do these interventions in public sector settings. So that's been the goal of what we've been wanting to do.
And training occurs in different ways. And one of the professional groups that we were concerned about were pediatricians. And they are the first line often when kids come in, the parents bring them in, and there are some concerns that might be around behavioral health.
Let's flip back. I want to.
So do you want to talk
Yeah,
about that for a minute? I think that's an important part.
Of House Bill 1088. I have a slide later on that shows that half the children who are Medicaid eligible in maybe we could find that one, the one with the circle. Can you find that one? Keep going. Half the children in the state of Washington who are being managed on psychotropic medications, who are Medicaid eligible, had no psychosocial intervention. So they were either being managed by a primary care practitioner or they were managed by a nurse practitioner or managed by a child or an adult psychiatrist. So, here we have, a child who, in fact, there is the rare child that you just give them a little medicine and it's going to be okay. But most kids that are seen, particularly kids who are in circumstances where there are more stressors, they need something else and their family needs some support. So one of the areas we were most concerned about is that number of children who are being managed in this way. So one of the outcomes of 1088 was to establish something called the Partnership Access Line. So any pediatrician in the state now, although it's still the resource is designed for particular regions, but any pediatrician in the state now can pick up her or his phone and when they have a child in their office and can talk to a child psychiatrist about not only the diagnosis but the treatment that they're receiving. So, and in addition to that, there is a program where practices that are outside of what are called practice parameters in terms of psychotropic medications are being reviewed. There's a second opinion being given, and in the case of medicine for attention deficit hyperactivity disorder, there's been a real significant decrease in the over-medication and overuse of those. And now there is looking at, because often in the foster care system, children are not necessarily, for their behavior disorders, not necessarily being managed with the target for managing a specific diagnosis. They're often being sedated for their aggressive and impulsive behavior. So that's another area we're really focusing in on. What is the number, Terry, in terms of foster care kids in terms of being managed on psychotropic medication compared to the regular population?
So for antipsychotic medications, kids in foster care are on antipsychotics at 7 to 8 times the rate of other kids on Medicaid because of low income.
And a significantly high percentage of those kids on antipsychotic medication receive no other treatment.
Yeah.
That's something that concerned the legislature very much, and still does, but that's being looked into. So, shall we go into my work?
I think let's keep coming here because we want to.
We're still going to go to the evidence-based practice
I think we
bill.
probably should start to talk a little bit about the bill that you did.
Yeah.
All right.
Well, let me just say real quickly, before we do that, I worked for SDRG, the Social Development Research Group, which is part of the School of Social Work. And as part of that, I did research on what the states are doing on evidence-based practice. And so we have that document available for you, as well as another one, an issue paper that came out while I was there at SDRG about evidence-based practice. But that work led me to believe that in Washington State, with all that had come before, it was time to do an evidence-based practice bill that applied to children throughout the system. So in the child welfare system, in the juvenile justice system, and in the children's mental health system. I very much wanted to see us work in a way where we could maximize the number of effective programs that were used with these kids and minimize the ones that had not been proven effective. Because frankly, we still had a culture where a great many of the treatments that were used had not been proven. So that's what was the driving force behind this bill.
So I think we've had enough discussions in this seminar series about the barriers, the challenges of implementing evidence-based practices. I think that there are a whole host of either challenges that are real, there are biases that are not necessarily based on what exists in the empirical literature. There are administrative and financial constraints that get in the way of doing evidence-based practice. And then there aren't evidence-based practices for every problem that exists. So there's this host of challenges have gotten actually gotten in the way of implementing these practices across the different systems. And some systems, as we indicate, you can mandate, and it seems like the mandate works very well. The juvenile justice system, there was a mandate, and in fact, those practices were implemented. In child welfare and behavioral health, it's been, in this state, much slower in terms of implementing these practices. So I think, again, in the PowerPoint and the description, I go through what we consider the various barriers, the challenges. We'll go to the next slide. And again, there's the costs, and then there is the capacity to provide the supervision, training, our whole structure in terms of we have a structure of funding within our public mental health system that is very much unit-based rather than outcome-based. There's a high caseload size that practitioners, clinicians are expected to do. So there are many, many challenges to actually moving in the direction of doing evidence-based practice. People's supervision and consultation are not paid for. There are many, again, the barriers are not insignificant. You can go to the next one. So given these barriers, and given the modicum of success that we've had in terms of moving forward, came to a point during this last year where, what are we going to do? What can we do to assertively move this system forward? And I think that's where Mary Lou began to look. Have other states done things that have demonstrated that are there legislative strategies that existed that could, in fact, really move the system in a more assertive, a quicker way forward?
And there are 3 other states that have significant pieces of evidence-based practice legislation. However, none of those states had that legislation involve the 3 areas that we are just talking about for children: child welfare, juvenile justice, and children's mental health, behavioral health. So I wanted to expand what we could do. And so what we have here is a summary of what the bill does. Let me just say very quickly that this is a summary of the final bill. There were about a dozen drafts of the bill.
Maybe you could talk a little bit about the initial ones and what your ideas were.
Yeah. And by the way, while I'm doing this, let me introduce my legislative assistant, who's in the audience, Carrie Boyder. Would you wave your hand, Carrie? There she is. And Carrie was with me with all of these drafts. It was quite a little drama, by the way. And when we started out, we wanted to have specific goals and objectives, numeric objectives that would be reached in the 3 areas. And they had to do with time frames. So, for example, in the juvenile justice system, by fiscal year 2014-2015, no less than 65% of the programs and treatments would be evidence-based practice. That was in the initial bill. In child welfare, by that same time frame, no less than 35% would be evidence-based practice. So you get an idea. There were different time frames for the 3 areas based on where they were. Well, that caused quite a bit of concern, as you can imagine, because people would have to change the way they were doing business. And they had legitimate concerns about, well, how am I going to get my people trained in this? And what if there isn't a treatment that works for my clients? And so we had to deal with those concerns, and many, many drafts later, we came up with the final bill.
So,
and I'm going to run and get some water, and I'll be right back.
So as you can see, the final bill is not a mandate as it relates to 35% of this and 45% of this and this percentages by particular years. It does require some very, very specific benchmarks to be accomplished. But the first thing to be accomplished in the idea is that ultimately what the expectation for the state is that it would in fact use its resources increasingly for evidence-based practices across child welfare, behavioral health, and juvenile justice.
And in fact, we wanted to grow the number of evidence-based and research-based practices in Washington and help our community organizations by training them in how to do that.
You can go next one, Gabby. So, go ahead. And why don't this is on our website, so these are our frequently asked questions, and we think it's a good way of going through. So let's start first off on I think we've described what the purposes of the law are. So the first step in this process is that the Washington Institute of Public Policy, in conjunction with our Evidence-Based Practice Institute, would define what is an evidence-based practice, what is a research-based practice, and what is a promising practice. In law, there are those definitions, but the legislature this legislature wanted us to take a look at those definitions and see whether there were ways in which we could either improve on them or, in fact, validate them as the appropriate definitions. So, as you'll see, and I'll come back to talk about this, we are proposing new definitions which will go to the legislature this coming January, which include two other factors and two major changes. One, that we want to look at what is we labeled heterogeneity. Are these evidence-based practices, have they, within the research that's been conducted, actually included a population analogous in terms of minority representation that exists in Washington state? So essentially, these studies needed to represent 32% of the population in these studies need to have at least 32% minority representation. So I think that's one of the clear feedback we were getting from community providers, that in fact, how do these practices align with various minority communities and other communities? Have they actually demonstrated effectiveness? Would there be a necessity to adapt or do something different with the practices? So you'll see on the matrix that when the meta-analysis were done, we looked to see whether there was at least 32% of the population. And then there are a variety of other ways we looked at some of the practices which might have been designed. A practice might have been designed for African American males, and that was the population that was designed. So we wanted to make sure that those also got credit for being either an evidence-based or research or a promising practice.
Now, did you want to mention cost benefit too?
Right. That again was the other factor, was being that the legislature is praise at the altar of cost benefit, particularly some of Mary Lou's colleagues on the other side of the aisle who are, if you say cost
However, I want to say that Democrats as well as Republicans are interested in cost benefit because we have a limited pot of money, and we only want to put it into programs that are effective and that won't cost us more in the long run than we can afford. So they have a benefit.
Suffice it to say, Mary Lou is downplaying. The vote on this bill in both the House and the Senate was unanimous. If you know and watch politics in Washington state and nationally, there's very, very few bills that ever pass that are unanimous. And so the issue of the effective movement towards let's improve services for children and adolescents, at the same time, let's do it in such a way as we can demonstrate positive cost effects, was very appealing across the aisle.
As well as accountability. The legislature's big on accountability.
So, Gabby, can we just flip to the matrix? So, and do we have them to hand out to people? Okay, all right. So, let's pull it up, and it's going to be hard to see. So, I was reluctant to do it, and it's not done yet. But I'm going to give you an idea what's there. So the way we went about it, I apologize. I mean, this is whenever I've been in the audience and someone does this, I'm outraged. So I understand. But you can go on the Washington Institute of Public Policy website and actually see this. So what we wanted to do is break down practices in terms of their current definitions and whether, in fact, they met criteria for evidence, research-based, or promising. And then we looked at ones that were targeted to child welfare, juvenile justice, and then general prevention and mental health. So, and we attempted to do these in such a way as that within categories, particularly within mental health category, we tried to do it by not just services, but by particular problem areas, anxiety, depression, things of that sort. So again, the first column would have, I'll just use one that would be, let's look at parent-child interaction therapy. So, let me choose a different one. I'm just thinking which would be an easy one to go through. Let's do. Do we have the mental health ones? I have them in my hand, but I don't have them up here. Okay, let me do multisystemic therapy. We just use that as an example. So it has a manual. For the population, you know, does it meet criteria for the current definition of evidence-based? Is yes. Go across, and with the new definition, again, it in fact is meets criteria for that, and the population in fact is has heterogeneity, and in fact has a cost effect that is positive. So that's essentially the way we went about it. So we did it by the basis of the current definitions and then the alternative definitions. Alternative definitions, heterogeneity, and cost effect.
Again, the groups that did this were WISIP, Washington State Institute for Public Policy, and ERIC's Evidence-Based Practice Institute.
Yeah. So let's go back to the frequently asked questions.
Now, as we're going back, I have noticed that nobody in the audience has raised their hand for a question. I am just amazed. So aha! The lady in the back.
I was waiting. So you had mentioned that you were interdisciplinary and you missed my profession, which is special education. So I'm curious how you actually included education in your discussion and your forming of this bill.
Good question.
I think the education was not specifically defined as that they're not required to allocate within the various designations for special education. They are not as part of this this bill. That in fact, that there's a great deal of interventions that go on within education, but it really was, this is really determined by the use of federal and state dollars that go through the Department of Social and Health Services and the Health Care Authority, targeted at behavioral health, child welfare, and juvenile justice. So despite the fact we all know the importance of education and what goes on there, it was not part of this bill. The legislature did not try to fold that into it. It would have made it incredibly complicated to do that with the number of school districts that have independent authority to do a variety of things, and the different federal designations related to special education and IDA. I think it was just felt to be outside the realm of this legislation.
Not that special education teachers don't have a role to play with behaviorally disturbed kids, and we can probably do a whole other lecture about that. And in fact, let's talk after the lecture.
So this inventory that you couldn't see, that you have to trust me exists, was done. It had to be done by September 30th. So it is in fact not comprehensive. We definitely missed programs that in fact would meet criteria for evidence-based research promising. But we needed to, in fact, as part of the legislation, provide at least the context and the format, how we were going to look at ones we could identify, these evidence-based practices, and the next step was required of the Department of Social and Health Services is for them to catalog the number of evidence-based practices that, in fact, are on that list. But we have a number of months where we're going to get feedback from the community as to what did we miss. For example, in the whole area of substance abuse, chemical dependency, we really need to expand that list. There are definitely promising practices that we want to make sure are on the list as we go around and get feedback from community providers and other people. The list is going to expand. But what is now required of DSHS is to go and figure out what are they paying for, how many of these exist. Again, what the notion is that we're going to come back and begin to expand on those come the next two legislative sessions.
Now, let me just digress for a moment and say there are bureaucratic barriers in the way of doing some of this stuff. And one that comes to mind is in the area of behavioral health. Since the passage of 1088, House Bill 1088, we have wanted to increase the evidence-based practice treatments in behavioral health for kids, and to do that we need to measure whether or not a child received an evidence-based practice. The federal government will not allow us currently to track whether or not a specific provider on a specific session was using an evidence-based practice. We can't code that way. And so we're having some problems. This is despite the fact that another part of the federal government is saying it wants us to go more and more towards evidence-based practice. So there are some bureaucratic barriers. Just wanted you to know that.
So by December of next year, the Health Care Authority and DSHS will have to report to the legislature what have they counted, what have they been able to identify, as well as a strategy that they're going to propose to increase the number of evidence-based practices. That's their obligation. You keep going down, Gabby. So, come back up. So as Mary Lou describes, there could be impediments, but again, the expectation is if there are impediments, they're going to have to be described, and what strategies that would be figured out to undo the impediments.
And we're thinking right now of a workaround to deal with that federal issue I just described.
One of the areas of, as I've mentioned, of major concern, and this is a major concern for smaller community providers, and particularly providers of services to minority, ethnic and racial and minority populations, is they've developed often interventions and practices that are designed to meet the needs of a particular ethnic or racial group, and there's not, they won't necessarily appear on any list. And there's as we go and talk to these different providers, there is a very strong sense that they're going to be put out of business because of this. Because how are they going to implement and continue to do the things they do, and where are they going to get the resource to be trained? And also, do they have practices that may in fact be bringing about positive outcomes for the populations they serve? So one of the major emphasis that we're going to have is to work in collaboration with community providers on how in fact they can get on the list, how in fact a practice could be perceived as promising and move up the pathway into research and hopefully evidence-based. Not an easy, as any of those of us who've engaged in this work from a research perspective, not an easy task, but really an obligation on our part to engage the community in such a way as they, in fact, have practices that have demonstrated to be effective to get on this list.
Can you give us a few examples of that, or at least one?
We were the other day at Asian Counseling and Referral Services, and they have a particular intervention that they've developed for young men who are abusing and using substances. Their sense is that this is a very effective strategy that they have. They've developed some, not exactly a manual, but they've been doing this for a long time, and they think that they have data that can demonstrate that they've improved outcomes. So what we're intending to do, and we're figuring this out, we're intending to work with agencies around, well, how can you get from, gee, this is something we've been doing for a long time, to where there is much more documented and empirically supported evidence to support it. So in fact, it will get on the list. So that there are, within a number of Native American communities throughout the state, they've developed various interventions for youth that, again, the community feels very strongly these are very positive interventions. So we want to work together with those agencies to see whether we could support and provide technical assistance. The other thing that we've found is that many agencies, now that this is a law, now this is real, are very eager to see, can someone provide us with the training? Because we'd like to do FFT, or we would like to do various approaches that treat trauma in a more effective way. But we've never been able to, where can we get the resource to do that? So this will be partly the guidance that this legislation will provide to DSHS about how are you going to spend your dollars to in fact support training, so agencies who are motivated to do this can in fact be supported to do it.
And DSHS does have training dollars that they can use, and there are federal grants out there that actually have already been given that can be used as well. So it's a matter of where are we putting our priorities.
You have any questions about what we said so far? Yeah.
I actually have a question about the whole training piece of it, because it is an issue for you. Because it is an issue, particularly for smaller organizations, about how to fund and keep your workforce trained, because it's expensive. One of the questions was, you mentioned the Interdisciplinary Training Institute and several hundred people. What happens with agencies that have already had their people trained, maybe through Harborview or some of the other places in PCIT or Trauma Focused CBT or CBT Plus? Are those going to count towards you do the practice? And then how do you maintain, you trained your people, but are you actually getting the consultation and
Right. So those practices are, when you see the list, they fall somewhere. So TFCBT is there's evidence for it, and PCIT, there's evidence for it. CBT plus is something we've, a group of people have developed, so there needs to be more evidence for it. So those things will in fact be on the list, and people will get credit for doing those.
So they don't have to receive their training from the Evidence-Based Practice Institute.
But the point you make is really an important one. How do we know that someone is actually doing those practices? So what are the adherence and fidelity measures? How are they being managed? Where is it being? So that's one of the discussions we're going to be having. How can we support agencies in such a way as, if you're a supervisor at SMHI or somewhere, wherever it is there a way in which you can sort of easily be able to provide the support to the various practitioners who are doing those? And how can the state be assured that in fact you're getting the amount of consultation or supervision that's necessary? Again, this is going to, I'm saying it rather, this is going to be easy, but it'll have to be a very significant shift in terms of how one thinks about resources, because as we know, in order to maintain one's skill set, consultation and supervision is really critical, and it's not something that's often part and parcel of how agencies are supported. They're supported for the practice, not necessarily for the consultation and supervision. So if in fact we're going to continue to move in this way of being effective in expanding evidence-based practice, there's going to have to be a shifting of allocation around these things.
Mm-hmm. Under the contracts.
I think that's way, I think, as you know, way more easily said than done. Around
Another issue that comes up is when staff are trained in these evidence-based or research-based practices, they become more valuable, right? And then other agencies might want to steal them away. And in fact, briefly, for a little while, that happened between JRA, Juvenile Rehabilitation Administration, the juvenile justice arm of DSHS, and the Children's Administration, another arm of DSHS. Mm-hmm. So the Children's Administration was raiding staff from JRA. Now we have more staff in Children's Administration that are trained in evidence-based practice. Still more need to be, but there's more of a level playing field. So yes, I expect there will be those bumps in the road, because you're not going to get everybody in the state trained all at once on evidence-based practice. But as the implementation moves along, more and more and more people will be trained in evidence-based, research-based practice. And who will benefit? It will be the children and the families, and also the staff themselves, because they will be providing effective services and they can see the outcomes of that.
Mary Lou, we've described, and this is available on our website. Mm-hmm. Could you just come back, and because I think it's such an interesting circumstance, the legislative process that you had to engage in to bring this about, and what were some of, I think we've already mentioned some of the challenges, but mm-hmm. the kinds of things that you had to do in order to bring this about.
Well, I mentioned that we had 12 different drafts, maybe even more, of the bill, and I met with stakeholders during the summer to try to pull the bill together and get the necessary elements. And many of the stakeholders were excited about it. They were child advocates. They said, "Yay, team, let's do this." But then when they saw that their own agencies might be involved in reaching these higher objectives, they started to get a little bit uneasy. And so I had to deal with that. I had to deal with the partisanship in Olympia, and the way I did that was I took my research about evidence-based practice among the states, and I met with the minority leader. Now, I'm a Democrat. He's the leader of the Republicans in the House. And I asked him if he would look at my legislation and see if he could support it, because I felt that it lined up with some of the values of his caucus: accountability. People want effective programs. And there were a couple of Republican states that had actually enacted evidence-based practice. And I showed that to him. And he thought about it and thought about it and decided to come on board, and he brought his leadership team on board with him. That was a big deal, a really big deal. And, you know, I was really kind of nervous about doing that, because we don't usually go over and have these long conversations with the other team. But I thought that it might work, and it did. I would say that we had an easier time in the House, even though we had several different versions in the House, and we had DSHS coming in and meeting with us, and we have the different divisions of DSHS meeting with us, some saying one thing and then in back of us doing something a little different. And so we had to deal with that. And but we did. We got it out of the House, and then it went over to the Senate, where the advocates who were nervous about the objectives in the bill really came down heavy. I mean, real heavy against the bill. And just raised a complete ruckus about it, throwing out scenarios that actually were not ones that were close to reality, but it's some of the things that are done in lobbying. And so some of the things that they brought up were really very reasonable, and others weren't. Finally, at the last possible moment, we got the bill after I agreed that we would significantly modify it and take out those numeric objectives that I had read to you about. So we don't have those strong numeric objectives in the bill, but we do have a strong process in place to bring about what I believe is effective programs for kids in Washington State. And I think the payoff will certainly be there for the children. And in the end, we will have a state where I think we're going to have decreased crime and decreased numbers of kids who will need the child welfare system and who will need to be put in institutions to receive mental health. I think those numbers will decrease.
Yeah, I think that's. I think that you're to some degree downplaying the amount of interaction that it took, the talking to your colleagues, talking
Right.
to stakeholders, talking to advocates, talking to lobbyists.
Yeah. And it's true that we had to really do a tremendous amount of meetings and talking and trying to deal with concerns. I actually reached out to our minority caucus in the House. We have minority members who've established a caucus. It's called the Diversity Caucus. And I asked them to help me with bill language that would deal with the concerns of minority communities, and they did. They were really wonderful with that. I knew that I needed Eric's help, and Eric is not a paid lobbyist. And most bills that pass have paid lobbyists. because I couldn't be over in the Senate all the time, for example, because I had to be a committee chair and I had to be present in my own committees.
Mary Lou would give me lists of people. That I
And
needed
so
to talk to.
Eric, God bless him, would go over and meet with senators, especially a particular one, Senator Hargrove, but many others as well, and Senate staff. And I really would tell you that this is a team effort between Eric and myself, and then there were many, many other players as well, but a team effort to get this bill passed. So Eric is my co-conspirator in this.
Yeah. Well, I think what really worries me and should worry people in the state is that you are stepping down and moving into a different phase of your life, and to say the least, your advocacy and the work that you've done, it's irreplaceable.
Well,
so,
thank you, Eric. Actually, I want you to know, and our audience to know, that I will still go down to Olympia and kick butt if I have to. I'm still going to advocate for this, and I love the people in Olympia, and so any old excuse I can get to come down there and talk with them will be good for me.
yeah. Thank you.
So, are there any other questions? We'd love to answer them.
Yeah. What would you say are the one or two biggest barriers you anticipate in the next couple of years, and any preliminary thoughts on how to approach those barriers?
Well, I would think one of the barriers would be the significant personnel changes that are taking place in DSHS. Mm-hmm. And so the leaders that were there with us during this last year, a great many of them are going to be gone or in different positions. And so there'll be a whole new need to re-educate and to build the fire and the passion for evidence-based practice for kids. I think we'll do that, but it's going to take some work. And bureaucracies can be very, very good in putting up barriers to just about anything that they want to put up barriers to. And so we'll have to get the leadership sold and the mid-leadership, mid-management sold on evidence-based practice. But it is the law, and so we hope that will make a difference to them.
Yeah, I think the structure of our system, as I think I've talked about and most of you know, is very much unit-based. Number of times you see a child or a family, a tier system that in various places that doesn't necessarily fit nicely with doing some of these practices, and agencies are not. We're going to have to figure out how agencies are supported and to do some of these things. The other is the Affordable Care Act. What's the impact of health reform, being that the intent is to integrate behavioral health and primary care in very, very significant ways? So what are the benefit packages that are going to come, and how are we going to incorporate these evidence-based practices into a different funding structure and strategies that we're going to have for healthcare around the country? So I think that's of course the economy is a big driver. You know, how many dollars are we going to have to in fact allocate? And then there's vested interest in keeping things just the same way. So again, if you don't have the kind of advocacy that Mary Lou had at the legislative level, the power and the resistance to change is pretty significant. So, you know, those are all aspects. So to get a constituency, particularly a broad range of constituency, who's saying, this is what we want to do, this is the way we want to move forward, rather than this is going to get in our way and you shouldn't be telling us what, somebody else shouldn't be telling us what to do. I think that's going to be critical to develop a group of people, a group of providers, an advocacy group that are going to be sort of moving this forward, rather than it coming from the legislature and from the university. And that's going to be really, so I think that's the importance of getting going here with moving providers in a direction, or them choosing to use some of these practices and being satisfied and enthusiastic, and the community is being satisfied. And then the community and the citizens of the state saying, this is what we want. We don't want things that are mediocre and where there is, nothing that really supports it. We want these practices, and that again will have something to do with how do we educate a community around these kinds of things. So,
Well,
thank you.
Oh, we've got one.
Sue.
I do just have one question. I don't know if do you have time? You mentioned, Representative Dickerson, that you had to take out the language around the benchmarking numbers over time. And so I was just wondering, what would represent success to the legislature with this bill if we kind of don't have the numbers to benchmark against? Are there other things that the legislature is really looking to indicate that this is?
Well, we will have numbers.
Yeah.
We will have benchmarks saying that in child welfare, 30%, we're going to have real numbers. So
right, but so it's like
not
an
written
increase.
into the legislation. There's a process for the development of those numbers based on the work of Eric's group and WSIP together. They're going to come up with the numbers. They're going to issue, a report on what's the baseline now, what have we got going in Washington State now, and then what do we believe the benchmarks should be. That report will be given to the legislature. That will be essentially the law of the land unless an agency comes forward and prospectively says, we can't meet this and this is why, and convinces the legislature that that's the case.
So that's going to be the challenge, that there will need to be legislative enthusiasm for moving in a progressive way from where we are now to wherever we set the bar. Yeah.
So I want to thank everybody so much. This has been a lot of fun, and thank you. And Eric, I want to thank you for inviting me to join you in this.
Oh, thank you.